Good evening. Peter Greenhouse, consultant in sexual health from Bristol, here today in Ukraine.
Доброго вечора.
Доброго вечора.
І дякую вам за запрошення.
Дуже приємно. Дякуємо. Thank you so much for coming. Is it your first time in Ukraine?
First time in Ukraine, yes.
Great. Hopefully it will be pleasant and will not be the last one.
Hope so.
So you came from Bristol and you were the first known to conjoin STI diseases as venerology with a gynecology.
That's right. It's two subjects in one, if you like.
How do you call it now?
Well, I call it sexual health.
Okay.
Sexualny zdorov, or something like that. I'm sorry, my Ukrainian is not very good.
Perfect.
But
sounds well.
Okay. But the whole point is that most women will have some gynecological problems and most women will have had sex. If you mix into that the fact that most sexually transmitted infections cause very little symptoms, and most people who get a sexually transmitted infection will get it from somebody who themselves do not know that they have it. Lots of us will have infections. If we test your audience, for instance, we go out to the audience and we test them. Maybe in their lifetime, 1 in 10, maybe 1 in 3 will have had chlamydia. Isn't that a nice thing to know? So the point is that most gynecologists will test for some sexually transmitted infections, but not all the time. And there was a time when most people practicing venereology had no experience of gynecology, and the women fall in the gap between the two. So it was necessary to put the two subjects together. Also, it's much easier to sort out the contraception at the same time as checking for infection. It's simply logical to do it.
Okay, I've got. So according to your opinion, all the problems in gynecology, they came from a situation when two people considering themselves healthy meet together and...
Well, not all gynecological problems are due to sex, but for women under the age of 30, most of the problems they get relate to the problems of sexual activity, the problems of needing to have contraception, the problems of having pain with sex or period pains. So they relate either to hormones or to infection. So for instance, hormones may be the main cause of bleeding, but in my lecture tomorrow I will actually show that infection causes a lot of endometritis and therefore a lot of unknown, undiagnosed bleeding. What about pelvic pain? Most people think that infection causes pelvic pain, salpingitis, but in fact the principal cause of pelvic pain in women, recurrent pelvic pain in women, is endometriosis. Now most of the women I don't know how things are in the Ukraine, but most women who've got pelvic pain in the United Kingdom go to their family doctor or a sexually transmitted infection clinic. The doctor thinks they have an infection and they get an antibiotic. But 10% of women have endometriosis. So those women don't need antibiotics, they need hormones for their treatment. So the women who go to the doctors, to the family doctors and the sexual health doctors, get antibiotics when they need hormones. But the other way round, women who go to the gynecologist with abnormal bleeding, with intermenstrual bleeding, are much more likely to have chlamydia than to have some hormonal problem. These women get hormones when they need antibiotics. So you have to do the two in one subject.
Well, so one of two.
Yes,
The chance to guess is quite high.
Yes, one or other. Well, that's why if you have a what I call a holistic approach, where you're not just interested in what's going on in the genital area, you're interested in the hormones, you're interested in mental health for the women as well. So the contraceptive hormones, for instance, are very important for women, but each woman reacts individually and differently, and it's genetically predetermined. So there are so many variables in women's health. That's what makes it so exciting.
Yeah, really. And since the time when we invented contraception that do not prevent from STIs,
Of course.
we got into problems actually.
Of course.
Only double Dutch.
Yes,
yes,
only double Dutch. Right.
Thank you so much for that point. But in fact, the last thing I wanted to do to make this ridiculous. So I really consider that a lot of problems came from a situation when a woman considers herself being healthy as well as the man, because no pain, nothing goes out from my penis.
That's right.
Let's have sex.
Yes, good idea.
What is the way to prevent the problems in this situation? Because, for example, okay, I have a new sexual partner. let's stop for this evening, only champagne, let's go to the
Yeah, well,
laboratory.
that's interesting, you see, because 20 or 30 years ago, if you had got to that wonderful time in the evening when you know that the woman knows, that you know that they know that you are going to, you may be about to have sex. Wonderful, congratulations. If at that time you had said, we're really interested in each other, I tell you what, let's go to the sexual health clinic and get a checkup, they would have thought you were completely mad. Nowadays, it is the only sensible thing to do. You either get a checkup, make sure you're healthy, and then go away and enjoy yourself, or you use condoms, and then eventually you go away and get a checkup. So there's lots of different ways to behave. Here's another problem. You have in your pocket, most people in their pocket, have one of these little devices here. And isn't it wonderful to know that with the right apps on the phone, you could find the nearest available sexually interested person in the conference tomorrow or even tonight. That's a fantastic opportunity that my generation never had. And the problem is, of course, a lot of young people are now using this opportunity to change partners more rapidly. And the most important thing that determines how fast a sexually transmitted infection will spread and what the rates of the infection are is how quickly you can change partners.
Really?
Have you ever
Does it really work?
Of course it works. Have you ever used Uber to get a taxi?
No, I'm too old school.
The whole point about Uber is that you can find a taxi much more quickly, and to use
very popular in
to use an analogy, it is much easier to get a ride. And it's the same for Tinder, and it's the same for Grindr.
Well, now I regret that I have no cell phone in my pocket.
Sorry.
Because I always thought that if they show me a girl that wants to have a sex just 200 meters nearby, I thought they are going to sell me something. For example, some
No. There are lots of what we would now call amateur enthusiasts.
Okay.
I mean, wouldn't the world be a very boring place if people were not enthusiastic about sex? That's why we call it sexual health. It's for people who are sexy and want to be healthy.
So will it be correct just to just share with me that experience? Should I write first, hello, I'm Victor, please send me your HIV, hepatitis B, hepatitis C, syphilis, gonorrhea, chlamydia, mycoplasma, neuroplasma, something like this?
Yes, that would be, well, that's interesting. Of course, if you're working in the porn industry, if you're working in pornography, you have to come in at work and it's on your phone and you have a certificate, but I don't think things are going to go like that in real life.
Okay, what a wonderful world.
It's only in the movies.
I've got. So, in fact, for example, if two people meet and they would like to have some relations, the only way is to start with a condom, actually, if they
That's the sensible.
they are in a hurry.
That's the sensible thing to do.
But they will not prevent HIV, or for example...
Well, interestingly, a condom is very good at preventing HIV because, and this is
HPV, I'm sorry.
HPV.
HPV.
No, not HPV. HPV is ubiquitous. So, for instance, let's just think for anyone in the audience or anyone in the public. I will ask you a simple question. Have you ever walked around a swimming pool in bare feet?
Yeah.
Yes, of course.
I always do that.
Then you have HPV on your feet, but you may never get an actual wart or a verruca on the foot. So, have you ever been to a primary school and walked across a road in a crocodile with other children? You hold hands with other people, you shake hands, and in your first year at school, one child has a wart on his thumb. Yes, and he shakes hands with everybody and plays with everybody.
Did we go to the same school?
Well, no, maybe, I don't know. But almost everybody has been exposed to wart virus on their hands and their feet. So I will ask you the question, you don't have to answer it. Have you ever had sex? Well, if you have had sex, you've probably been exposed. And the figures are approximately, by age 25, 90% of normal sexually active people have been exposed to human papillomavirus. Wonderful, isn't it? But the body has a wonderful way of healing. And as Albert Singer was explaining before, if you have a normal immune system, even if you have high-risk HPV, your body will get rid of it in about 6 months or a year, provided your immune system is normal. So if you're a very severely, poorly controlled diabetic, if you're on steroids, if you have HIV, or if you smoke, your body will not get rid of the HPV, and the HPV will stay there for 5 or 10 years, and you have a much better chance of cancer. So this is something that everybody needs to know, that if you smoke, you are much more likely, A, to get warts, visible warts, and B, to have high-risk HPV staying there for a long time. So the best thing to do is not to smoke.
Well, I think that STIs as live organisms, each of them, they have their own character, I would say.
Yes, of course.
Which is your beloved? Which is your favorite
Well,
one?
It has to be chlamydia, because that is the commonest sexually transmitted infection, and it has a very wide range of side effects. It's the principal preventable cause of infertility. It causes ectopic pregnancy. It causes abnormal bleeding. And most of us will get it. And thanks to our immune system, a bit like HPV, we will get rid of it in perhaps 6 months or a year or 2 years. So most people are never harmed by chlamydia. They catch it, they pass it on, and they get better. But depending on your immune system and your genetic predisposition, some people, particularly women, are more likely to get tubal damage or ectopic pregnancy. So for instance, with ectopic pregnancy, only about 1% of women get ectopic pregnancies, but maybe 30, maximum 50% of women will have been exposed at some stage in their life. So it's this individual response to chlamydia that is the thing that's really most exciting about it.
Well, as obstetricians, we more or less are pretty sure that chlamydia is related to certain obstetrical complications. For example, to preterm labor due to rupture of membranes, whatever.
That's right.
What about mycoplasma and ureaplasma?
Well,
till now, there
yes.
are a lot of, let's say, debates.
The debates. Okay, well, let's just to reiterate with chlamydia, it is reckoned from the best study that was ever done was an open study in Rotterdam, the so-called Generation R study, published in about 2001, where they followed, published in about 2010, where they followed a large number of women, checked for chlamydia throughout the pregnancy, and did not treat them. And they found that chlamydia was responsible for approximately 14% of all premature labor between 27 and 34 weeks. And in fact, the relative risk of premature labor for chlamydia positive versus chlamydia negative was 4.1. So this is a very good reason to test for chlamydia in pregnancy.
Really, routinely.
It's not, in England, we don't do it because they don't accept the evidence. But I think that's very strong evidence that checking for chlamydia in pregnancy would be good. Now, the evidence for mycoplasma, and certainly the evidence for ureaplasma, is very much poorer. We have a problem in the West, if you like, or the Western Europe, with ureaplasma, particularly ureaplasma parvum. We think that ureaplasma parvum is probably a commensal organism. And in women, quite possibly, ureaplasma ureolyticum may well be. Because if you just test a large number of women who are not pregnant, you may find that 20 to 40, maybe even 60% of them have ureaplasmas in their genital tract. But only about between 0 and 5% have Mycoplasma genitalium. So the organism we're most interested in is M. genitalium. Now, there have been a lot of studies done. Perhaps the best one was done by, I think, Lilia Tikhonova or Lilia Rumanskayeva in Russia, and it actually won a prize at one of the conferences at which I was a chair. I was actually chairing the session. This was in Tbilisi in 2010, and they checked for all different types of mycoplasma and ureaplasma and found no relation, no excess incidence of premature delivery. However, that research was done 10 years ago. It would be nice to find a junior gynecologist now who does his or her PhD and finds maybe more detailed information. Right at the moment, I don't think we can blame, if you like, mycoplasma or ureaplasma for premature labor. But I would be very happy to see the data from anybody in your country or anywhere in Eastern Europe who's done the work. We haven't done enough of this work in the West because certainly in England, most clinics don't have the opportunity to test for Mycoplasma genitalium. So this is something that you have the opportunity here in Eastern Europe. But with that opportunity, you get that opportunity through a multiplex test. So you're testing for M. genitalium, chlamydia, and several other things. That's good. But if at the same time you're also testing for ureaplasmas, which may be commensal, and you have a positive test for ureaplasma, and the woman thinks, oh my God, I've got an infection, I need antibiotics. Many of those women are getting antibiotics that they don't need. Now, the more antibiotics you use, the more antibiotic resistance you create. And the biggest problem at the moment we have is testing many women for chlamydia, or screening as we do in the UK for chlamydia, and giving them a simple treatment with 1 gram of azithromycin. Now, if you treat with 1 gram of azithromycin, you only treat about maybe 90% of women. But if they accidentally have mycoplasma at the same time, and you only give 1 gram of azithromycin, then about 15% of those women will develop resistance, antibiotic resistance to azithromycin. So they'll have mycoplasma that has resistance at the 23S RNA gene. Now, if every single time you take a group of women and you treat some of them with a small dose of azithromycin, the standard dose of azithromycin, then you're gradually building up more and more resistance to Mycoplasma genitalium. And now we're in a situation in some parts of Europe, for instance, in Greenland, all Mycoplasma genitalium in Greenland is resistant to azithromycin. All of it, 100%. In Italy, there are some studies showing 60, 70%. The latest study from one centre in Britain showing 80% resistance. So we have an antibiotic that doesn't work anymore. It used to be a first-line antibiotic for chlamydia. It's still a first-line antibiotic, but only if you give a higher dose. And there's another problem.
For more days.
For more days. You need to give 1 gram, and probably a 3 gram dose or a 2 gram dose spread out over 3 or 4 or 5 days. And only by using that treatment will you prevent resistance. Now, that's all very well, resistance with Mycoplasma. But the problem with the drug is it lasts in the body for many days. It's therapeutic for chlamydia for 10 days. But it has what we call a very long tail. So after 10 days, it goes underneath the treatment level for chlamydia. But that tail goes on for another week, maybe another 10 days. And if, during the next 10 days, you have sex with somebody and get gonorrhea, you can imagine there'll be a whole load of people around the place who will be might be catching gonorrhea when they have a very small amount of azithromycin in their system. And you don't have to be a genius to work out that in a few years, most of the gonorrhea will become resistant to azithromycin, and that is exactly what has happened in the United Kingdom over the last 10 years. So we are losing the drugs to treat the most important infections, and that's a very big problem. So the simplest sexually transmitted infection, chlamydia, uncomplicated chlamydia in a woman, your first-line treatment may not work completely. And even if it does work completely, if there are other accidental infections at the same time that you haven't diagnosed, you're going to create resistance. So it's almost as if simple sexually transmitted infections are no longer simple to treat. And it doesn't matter whether you're a sexually transmitted infection expert or a gynecologist. In fact, any human being, regardless of their profession or their background, should be worried by that.
Yeah, it's amazing, all these stories, because we can come to a situation that in 5-7 years we'll have no tools to treat the simplest problems.
That's right.
And that's something that the whole, let's say, community of doctors should take responsibility for.
Absolutely. I mean, we're getting a problem now with metronidazole. I think you were thinking of talking about trichomonas. Well, the more people use metronidazole, the more likely there's going to be resistance to it. And
that's really, thank you so much for raising that topic, because I have 2 points here. That when we are talking about treating of infections during the pregnancy, do you know that a huge trial that was actually stopped because they were trying to treat trichomonas during pregnancy, and they received increased level of preterm labor group of treatment.
Yes, well, I'm aware of that with bacterial vaginosis. And interestingly, the treatment trials for BV, bacterial vaginosis, using metronidazole, the only treatment trials that worked were where they used metronidazole plus erythromycin, or where they used clindamycin orally. Now, clindamycin will treat bacterial vaginosis. It doesn't treat trichomonas. But the problem is, of course, erythromycin and clindamycin also treat chlamydia, and probably also treated some mycoplasma. So what that early work showed was that although bacterial vaginosis is associated with preterm labor, it may not be the cause. It may simply be an indicator that some other infection is present. Now, as far as trichomonas is concerned, the same thing probably happened as well, because the trichomonad organism will cause inflammation or irritation. Whether it's enough to cause preterm premature rupture of membranes, I really don't know. But if you know of a study where they've actually diagnosed trichomonas and treated with metronidazole and got a higher level of preterm labor, then that's obvious that the trichomonas is not to blame.
Definitely. What about the diagnostic of trichomonas for today? PCR or culturing?
Well, the traditional diagnosis around the world has been wet prep microscopy. You look down the microscope, you see the organism, and culture. Now, the problem is that the old-fashioned culture, you take a swab, dip it in, it waits for a few days and maybe then goes to the laboratory. The sensitivity of that particular system compared to modern PCR or TMA, transcription-mediated assay, where you can do the test on the same test as you do for gonorrhea and chlamydia. Those new tests were trialled in Bristol 2 or 3 years ago and shown to have a much higher rate of trichomonas. And it was also shown that although in Britain most doctors thought that trichomonas was confined to certain sections of society, particularly immigrant societies, in our area in Bristol, it was simply found to be related not to race or ethnicity, but simply related to poverty. So the poorer you were, the poorer areas had more trichomonas. But there were 1 or 2 areas that were not very poor where there was a bit more, and we still really can't understand it. Of course, the problem with trichomonas is most women aren't symptomatic. And in men, trichomonas does not survive very long under the foreskin, and it survives even less time in the urethra. So most men will not ever get any symptoms, and of course they won't be diagnosed and they won't be treated unless their partner's been treated as well.
Okay, too much interesting questions still to discuss, but not so much time. Tomorrow we'll have a full day and we'll have a lot of interaction and a lot of communication. Just maybe the last question for today. We always try to talk about the future. So what is the future, I mean, of relations between STIs and human race? Who will win?
The problem is that now we are starting to lose the antibiotics. The infections are starting to win, but also it's our own human behavior that is increasing the rates of infection. And once again, I've shown about the mobile phone, the rates of changing a partner, but it's also societal breakdown. One of the most tragic things that affects rates of sexually transmitted infections in any population is war. And if you have a country like in Ukraine, where you've had a war for the last 4, 5, 6 years or whatever it happens to be, then in those areas it's very, very difficult for people to survive, for people to get to doctors, to have proper medical care. So the more disrupted your society is, the faster sexually transmitted infections take off. So in the long-term future, the long-term future is that we have to get much more clever at how we use diagnostics and how we treat patients with the right dose of the right antibiotic, and somebody clever has got to find some new antibiotics, or we're all going to have to just not have sex.
That's the option.
Yep.
A sad one, but still the option.
That's right.
Thank you so much for this amazing talk.
Okay.
It was a pleasure.
Okay. So good.